Hello, everyone, and welcome to today's webinar, Fully Humanized Mouse Models for Immuno-Oncology Preclinical Drug Candidate Selection. I am Antonina Salcido of LabRoots, and I will be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Miltenyi Biotech. To learn more, please visit miltenyibiotech.com. We encourage you to participate today by submitting as many questions as you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. This webinar is educational and thus offers free continuing education credits. Please click on the Continuing Education window at the bottom of your screen to obtain your credits. I'd like to now welcome our speaker, Sébastien Tabruyn, CSO at TransCure bioServices. Sébastien, you may now begin your presentation.
Hello, it's a pleasure to welcome you for this webinar. My name is Sébastien Tabruyn. I'm the CSO of TransCure bioServices. And in collaboration with Miltenyi Biotech, I will be happy today to guide you through the use of the humanized mice for immuno-oncology preclinical research. So just a few words about TransCure bioServices. 10 years ago, we started this CRO. We are now based in France, 70 collaborators, including 21 PhD. And we really have focused our company on developing a more predictive advanced mouse model. And among them, the two most important models, I would say, are the humanization of the immune systems. I will focus my talk today on this model, but also the humanization of the liver, so the ability to reconstitute human hepatocytes, a fully humanized liver in a rodent model. So let's go back to the humanization of the immune system. So being able to humanize animals give a powerful tools to then use those models for different disease platforms, disease model. The subject of today would be immuno-oncology, but we have gathered tons of data over the years on the use of those animals for infectious disease. We have a BSL-2, BSL-3 animal and lab facility where we can conduct HIV, HBV-related experiment. Model of inflammation, IBD, asthma, fibrosis of the lung, of the liver, GVHD. So all these models could be used to determine efficacy of action of a compound. The toxicity, the immune toxicity, can be also assessed in humanized mice. It's becoming more and more important nowadays to assess if your therapy will induce cytokine release syndrome, overactivation of the T cells, and so on. And being able to do it in the context of a full human immune system is very important. So this slide really summarizes what we mean by advanced human immune system mouse model. We start from highly immunodeficient animals, not SCID IL-2 receptor gamma mutated animals. Those animals do not have any B, T, or NK cells from murine origin, so you only get some residual macrophages that are partially defective because of the IL receptor 2 gamma mutation. Those animals are very good recipients for engraftment with hematopoietic stem cells. So CD34 positive cells are engrafted into those animals. We let the system maturate for 14 weeks, and we end up with a mouse that has a full human immune system from the dendritic cells, the monocytes, the NK, the T, the B lymphocytes. All the cells are there, functional, able to interact with each other. The first step when you want to humanize animals, it's to have good hematopoietic stem cells. And the purification of the hematopoietic stem cells from cord blood is performed using the Multimax from Miltenyi. So using this machine in combination with the CD34 microbead kit, we are able to achieve a positive selection of the hematopoietic stem cells with a high purity of 95%, with less than 2% of contaminating human CD3. And the ability of getting a high purity of hematopoietic stem cells is really key to get good humanized animals that will not develop GVHD over the time. The protocol that we use to humanize those animals is depicted on this slide. The first step is to make room in the bone marrow. And to do that, we have choose a protocol and optimize a protocol that is based on chemoablation. So we use busulfan to make room in the bone marrow of those animals before the engraftment of the hematopoietic stem cells. The choice of using the chemoablation rather than irradiation is based on the fact that irradiation are known to cause anemia over the time into those animals. So you have more robust animals using the chemoablation protocol, animals that are stable over the time for their health, but also for their humanization rate. The second advantage that we have is that we produce those mice in advance. So you don't have to wait 14 weeks to start your experiment. About 200 animals are humanized every week just to cope with the demand. So you can really start your experiment right after signature. Those animals have been QC by flow cytometry, and the main immune cells population have been characterized. All these human immune cells do express what they are supposed to express in terms of receptor. This is a non-exhaustive list of different markers that we use, I would say, in the day-to-day to characterize the main immune cells population. But really the take-home message from this slide is really that every time that we look at the different markers, that markers is expressed by the cell of interest, so no hole in the system. And thanks to the pickup fridge from Miltenyi, it's a really great tool to have easily access to antibodies. We can set up new panels for our customers, optimize those panels up to 14 colors per panel to really decipher how the human immune systems do react into those animals. Humanized mice, as I say, have a full reconstitution of all the immune cells population. But nevertheless, one drawback is the fact that myeloid, dendritic cells, even NK cells, are poorly reconstituted into those animals. The strategy that we have chosen to develop and optimize over the year is based on a technique called hydrodynamic gene delivery. Using large volume of saline solution that contain plasmid coding for those human growth factor, we can get a very transient, at a very moderate level expression of human cytokines. We have optimized different cocktails for myeloid, for dendritic cells, for NK cells, as you can see on this slide. Expression of cytokines will last for a few days, then goes back to the normal. But this transient expression of cytokines will have a profound and stable impact on the cell lineage that you want to boost into those animals. So on this slide, we can compare what is the normal situation. So non-boosted animals, you mostly have T and B cells. Percentages of NK, mono, dendritic cell are quite low. Thanks to the boosts with the different cocktails of cytokines, We can increase the percentages of monocytes, of dendritic cells up to 20%, but also the amount of NK cells within the system. We have also validated the fact that we can combine the two boosts into the same animals to get a little bit more of everything and being more close to what is the situation in a real patient. Looking at percentages is cool, is very informative, but sometimes percentages could be misleading. So having access to absolute count is also key to know what you are doing working with those humanized mice. You can see on this graph absolute number of cells per ml of blood. Before, after the boost, black dots, where we can show an increase in the absolute level of myeloid cells, monocytes. We have also investigated conventional plasmacytoid dendritic cells, DC type 1, DC type 2. All these cells were quite difficult to observe in non-boosted animals, but thanks to the boost, we can now set up protocols, studies that use those cells for the mechanism of action. Peripheral blood is great, of course. That's easy to interrogate without sacrificing the animals, but it's really just the tip of the iceberg. We know that the major organs are indeed infiltrated with human immune cells. So thanks to the GentleMax octodissociator from Miltenyi in combination with various tissue dissociation kits, we can get cell suspension out of any organs from these animals. So we have characterized the humanization rate and humanization quality of the spleen, the liver, the bone marrow, the intestine, the brain, the lung, really a comprehensive picture of what is inside those animals, boosted, non-boosted, and all these compartments, why are they important? Because they are really providing a source of human immune cells that can be mobilized when you challenge those animals, for example, with a tumor. Another example on this slide, now looking at NK cells population in boosted, non-boosted animals, boosted here with IL-15, that not only increase the total amount of NK cells in peripheral blood, but also the proportion of these cells expressing CD16. You can also observe on this slide the stability of the boost. So this is the situation before the boost, 1-2% max of NK cells. Thanks to the boost, we increase that to 5, 6, 7%, and this is stable up to 2 months. We have validated the fact that if more time is needed, we can apply a second boost and then therefore gain 4-5 months of higher rate of NK cells, monocyte or dendritic cells. So let's now discuss about what can be done in the context of immuno-oncology. So what can be done to assess efficacy, mechanism of action, safety of your drug acting on the growth of the tumors via immune cells. Or we also have customers that wants to see, and you will have examples about that, how by targeting the tumor cells specifically, there is also a contribution of the immune cells. So we start, of course, with these humanized mice, boosted, non-boosted. If we have to boost the animal is boosted 1 week before the engraftment of the tumor. Tumor are engrafted. Most of the models that we have developed are based on sub-Q engraftment, but we start to have more and more orthotopic mouse model as well. The growth of the tumor is followed either by caliper or by bioluminescence, if we have a tumor that expresses luciferase, for example. We follow the growth over the time. We can collect blood at different time points for PK analysis. When the tumor reaches the ethical limit, we do sacrifice the animals, collect whatever needs to be collected, and analyze by flow cytometry to decipher how the immune systems do react to the treatment. Most of the tumor that grow in non-humanized mice, in nude mice, can be grown as well in humanized mice. As a rule of thumb, I would say that about 95% of all the tumors that grow well in nude mice will grow eventually in humanized mice. But what you can see on this slide is that the immune system will react anyway to the tumor that you do engraft. And it can react on both ways, on both sides. It can either fight the tumor. That's the case for melanoma cells, known to be quite immunogenic. So those tumors will grow slower in humanized mice compared to non-humanized mice. But for some other tumors, you can have the other way around, the opposite situation. Glioblastoma will grow faster in humanized mice compared to non-humanized mice. It really shows you here that you have the two faces of the coin, the pro-tumor, the anti-tumor action of the immune system. So without working with IO-related drugs, you can see here that the human immune system that is reconstituted is able to interact with the tumor and create some microenvironment. So those tumors are indeed infiltrated. By immunohistochemistry, we can show that. We have all the facility in-house to perform IHC, chromogenic or fluorescence. You have here an example with CD4, CD8 positive human cells at the vicinity, but also at the center of the tumor. So it's a very homogeneous infiltration by human immune cells. But you will see in few slides that this infiltration is largely dependent of the CDX that you do implant. IHC is great, but for most of our customers, they want to have a more thorough investigation of how the immune cells infiltrate the tumor, are activated within the tumor. So definitely flow cytometry are key to go in that direction. So combining the flow cytometry capabilities that we have with 3 flow cytometers, up to 14 channels in each of them, with the GentleMag dissociator and the human tumor dissociation kit, we can get single cell suspension out of a tumor and analyze everything by flow to get a more comprehensive picture of how those human immune cells play their role. We can do that before treatment, of course, but we can also use that technology to characterize better the different models, the different CDX, PDX model that we propose to our customer. On this slide, you see hot versus cold tumor, example of hot tumor, MDMB231, more than 5 million of human immune cells per gram of tumor. That's a lot. Compared to RKO, colon carcinoma, only 3,000 human immune cells per gram of tumor. So you see that the window where you can play in hot versus cold is quite large. And we have customers that wants to face more challenging tumors with less infiltration, or we have customers that wants to start, for example, with a tumor that is well infiltrated, just as a proof of concept. Amount of cells, quantity of cells is important, but of course we can do better, and the quality of the immune system is also characterized. So we have about 35 different CDX models where we have this kind of data, and we can use those data to suggest the best model to our customer based on their mechanism of action. So as you can see on this slide, we have some tumors that are infiltrated mostly with T cells, CD4, CD8. Some tumors do have Tregs, some tumors do not have any Tregs. Some tumors are highly infiltrated with macrophages, some do not have at all. Some tumors have a large proportion of NK cells, so maybe a great model for ADCC related activity. So we can really play with all these CDX models to recommend the most appropriate model based on the mode of action. Another interesting feature of these humanized mice is the fact that the T cells in naive animals, in non-challenged animals, the T cells are quite acquired. So you do not have exhaustion or overactivation of the T cells. That's also why you don't get GVHD over the time into those animals. But the good news is that once those cells start to infiltrate the tumor, and you have here an example with HCT116 tumor cells, those cells start to express markers of activation, exhaustions, PD-1, CD68, TIGIT, and so on. So those immune cells are really able to do the job, migrate to the tumor, modify their phenotype accordingly. The first example here using MDMB231 to give you two messages. The first one is, as you can see on this graph, that already with n equal 5, so 5 animals per group, you can get very significant data, a very good TGI here using doxorubicin as a positive control. So that's the first take-home message, is that humanized mice will not increase the variability of your response. Sometimes we have scientists that do fear to start working with humanized mice because of the high variability. Really, the variability is more coming from the CDX model than the humanized mice per se. The second message from this experiment is that just by inducing apoptosis of the tumor cells, and therefore release of antigenic material, this is already sufficient to induce a dramatic infiltration of human immune cells. You get more dendritic cells, more NK cells, and even a switch, the M1, M2 macrophages balance. So just by targeting directly the tumor cells, you can see and imagine how you will get a better comprehension of what's going on in patient, because here you are working in the context of a fully humanized system. Humanized mice have a lot of success working with immune checkpoint inhibitors as a monotherapy or even as a combination therapy. So we have screened the different CDX tumor model for the expression of PD-L1. We can do that by flow cytometry in vitro. We also have data by IHC to characterize the expression of PD-L1 in vivo in the context of the human immune system. So once those models have been characterized, we started to see how those models could respond to a treatment based on immune checkpoint inhibitors. For a first example here with an anti-PD-1, so using Keytruda, 10 milligrams per kg, treating a gastric tumor CDX implanted sub-Q. What you can see here is that you have a significant but still modest TGI with 10 milligrams per kg of anti-PD-1. This is something that we do observe a lot. Working in the context of humanized mice, you will never get 100% TGI with immune checkpoint therapy as a monotherapy. So immune checkpoint inhibitor alone will never give you more than 30-35% TGI, even if you use what we call a responsive CDX. And the reason is that if you look at individual curve, here's an example with anti-CTLA-4, you see untreated animals treated with ipilimumab at 20 mg per kg. You can see that two animals do respond very well, 100% TGI, while the other animals do not respond at all. So it's really mimicking what is the situation in patient, with some patient responding very well to these new therapies, while some other the treatment failed, and we still don't know why. But not only you have access to tumor growth inhibition efficacy of your compound, but thanks to the TILS analysis, you will also get insight in how the immune cells do react. After treatment with anti-CTLA-4, for example, you can observe an increase of the CD8 T cells within the tumor, and as expected, a reduction of the human Tregs within those tumors. Most of the CDX, most of the PDX, if you treat them with a monotherapy based on immune checkpoint inhibitors, you will get very few percentage of TGI, sometimes nothing at all. That's the example here, using A375 melanoma cell lines. Keytruda in red, no efficacy at all. The blue curve is a T-cell engager provided by one of our customers, very modest TGI as well. But when you combine both, so when at the same time you release the brake and you push on the metal to boost the immune system, then you get the best. And you get a very synergistic, very significant TGI by combination of the Keytruda and the T-cell engager. So this is one example. Another example of this combination therapy and the synergistic effect that you can observe in humanized mice is depicted on this slide. So HCT116, left untreated, treated with anti-PD-1. You can clearly see that one animal do respond very well to the treatment. The 5 other animals do not respond at all. But when you combine the anti-PD-1 with monoclonal antibodies targeting the SIRP-alpha CD47 pathway that is used by a monocyte macrophage to do the job, then you get, once again, a very synergistic effect with almost 100% TGI. So innate immunity, myeloid cells, dendritic cells, NK cells, the functionality of these cells could be assessed as well in humanized mice. That's the key advantage of those humanized mice compared to PBMC engrafted animals, where you just take PBMC from adults, you infuse those PBMC into immunodeficient animals. After a few days, you only get T cells in the system. So only the biology, the functionality of the T cells could be assessed. Here, sorry about that. Here using the CD34 engrafted animals, you can get a full reconstitution of all the human immune cells, including monocytes, macrophages, and therefore you can test therapy, small molecules, monoclonal antibodies that are targeting those cells. Here an example with MDMB231, treated, left untreated, with small molecules targeting the M1 and 2 macrophages balance. It works nicely, significant TGI. That significant TGI is only observed in boosted animals. If you do the same experiment in non-boosted animals, you don't get enough macrophages in the system, so no efficacy at all. So really showing you the functionality of this boosting strategy in humanized mice. Same for NK cells, so ADCC related activities can be studied in humanized mice. An example here with melanoma cells, CDX implanted sub-Q, treated either therapeutic schedule, meaning that we start the treatment when a tumor reaches 5100 cubic millimeters, or a prophylactic treatment where we start the treatment right after engraftment. You can see that prophylactic schedule is working even better, of course, because you intervene sooner on those animals. But the take-home message here is that if you want to target NK cells, humanized mice can be used successfully. Another example of ADCC activity here, comparing test item 3, one of the drug of our customer, to an anti-CD38 commercially available that will target the myeloma cells. You can see here the positive control completely flat, so functionality at 2 mg per kg is great. The test item 3 at 20 mg per kg was not that great, but still we were able to show by flow cytometry that treatment with test item 3 was able to upregulate the amount of NK cells infiltrating the tumor. CAR T cells, immunosafety, efficacy of CAR T can be assessed in humanized mice in collaboration with the University of Besançon here in France. We published a few years ago this proof of concept showing that we can isolate T cells from the spleen of humanized mice. Those T cells can be manufactured to produce CAR T, and then those CAR T can be re-injected in animals coming from the same CD34 donors that the one that were sacrificed to isolate the T cells. So in this kind of study design, you work in a 100% autologous way to test efficacy and hopefully absence of immunotoxicity of your CAR T without worrying about GVHD or the elimination of your CAR T cells by the immune system. Oncolytic viruses, oncolytic bacteria can be assessed in our facility. We are equipped with BSL-2, BCL-3 animal and lab facilities, so we are trained and authorized to work with different biological agents. This slide to show you the comparison between IT intratumor versus IV injection. For this virus, it works as well, the two-way of administration. But we can also go a little bit deeper into this kind of experiment and assess the systemic immune response. So to do that, what has been done here and published a few years ago with Targovax is a first tumor implanted on the right flank, treated with the oncolytic viruses, IT injection, the first tumor completely disappears, and then we engraft a second tumor on the other flank to see how the T cells, the memory T cells, are there to protect against the second challenge with the tumor. And that's what you can see on this graph, the blue curve. Animals pre-treated the first time with an oncolytic viruses are significantly protected against the growth of a second tumor on the other flank. Speaking about vaccination in humanized mice, those animals can be used as well to test tumor vaccine. Tumor vaccine either based on naked tumor peptides or nanoparticles, dendritic cells loaded with such particles. You have here an example of animals, humanized mice, boosted humanized mice, vaccinated with MART1, so melanoma antigen. After few injections, you start to see in the peripheral blood clonal amplification of CD8 T cells that are specific for MART1. To do that, we used extramer staining. Another example, vaccinating the animal here with PREM1, dendritic cells loaded with PREM1, has been done in collaboration a company in Netherlands that would set up vaccine treatment in humanized mice. Once again here, after a few injection of PREM1 dendritic cells, we can challenge those animals with SCOF3 and observe that the animals that were vaccinated with the PREM1 dendritic cells were somehow protected, even if the effect is still modest. They were protected against the growth of the SCOF3 tumor cells. We can also observe, if we analyze the TILs of those tumors, that we have a very significant proportion of the T cells who are PREM1 specific within the tumor, so explaining why those tumors grow slower here in red. CDX can be engrafted, but also PDX can be engrafted in humanized mice. To work with PDX, we have a very nice collaboration with Immuno-Oncology, having access to their full database of PDX, very well characterized, more than 1,500 PDX. Those PDX, we've optimized and developed protocols to grow them in humanized mice. The strategy is in two steps. We first engraft those PDX in immunodeficient animals, let the tumor grow, resect the tumor, cut the tumor in pieces, and use those pieces of tumor fresh to engraft humanized mice. And by doing so, as you can see here, we speed up the process, the growth of the tumor, but also reduce somehow the variability of growth of those different PDX. So PDX, once they are implanted in humanized mice, can be, of course, used to test efficacy of different monoclonal antibodies, bispecific, small molecules, you can name it. Here, 4 test candidates have been tested in parallel in a model of PDX in humanized mice, where you can see very good TGI, but also being able to discriminate between a better candidate and a less good candidate in this kind of experiment. Those PDX are, as expected, also infiltrated with human immune cells. And as described for the CDX, the profile of infiltration is really depending on the PDX. And the data that we have really show that the Stills profile is really mimicking what was the original situation in the patient. So we are really one step closer to the clinic, working with PDX in the context of humanized mice. You can see on this example that we have a lot of macrophages. We have studied the M1, M2 macrophages balance, but little T cells, once again illustrating the fact that you can have different situations in terms of infiltration, and knowing well your model is really the key to have the best success in your experiment. So that was my last slide. Thanks again for your attention. Thanks again to Mid-Denny Biotech for organizing this webinar with us. It was a real pleasure. I'm glad now to answer any questions that you may have about humanization, humanized mice, or the use of those humanized mice for IO research. Let me know. Thanks a lot.
Thank you, Sébastien, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on that Ask a Question box located on the far left of your screen. We'll answer as many of your questions as we have time for. Now let's get started. Our first question is, did you notice differences of response to therapy in the presence or absence of myeloid DC boost?
Yeah, sure. I mean, the boost is really doing great stuff in those humanized mice. 2 examples. The first regarding the ability to use those humanized mice to check the efficacy of innate cells, for example, macrophages. We have experience with customers that were not able to see any significant TGI in non-boosted mice, and by doing the same kind of experiment in our boosted animals, they were able to show the efficacy of the treatment. Same for vaccination protocol. We know that the presence of dendritic cells, more dendritic cells in the systems, really makes a big difference in how you can elicit a T cell response or even a humoral response in those animals.
Great, thank you. Our next question, how many samples do you usually process at once on the Multimax, and how long does the cell separation process take?
So with the Multimax, we can virtually proceed up to 24 samples at a time. In the day-to-day, we receive cord blood. We have usually between 6 to 10, I would say, samples to proceed. And the whole process from the fecal purification to the isolation, the final isolation of the hematopoietic stem cells take between 3 to 4 hours max.
Perfect. Another question. You mentioned the CD34 cell purity after isolation was above 90%. Have you also checked the cell viability?
Yeah, sure. Cell viability is, of course, key for us. We want to engraft those animals with cells that are viable. In the day-to-day practice, we do observe most of the time a pure viability that is above 95%. So we never have observed any issue regarding the viability of the purified cells.
Thank you. We have some great questions coming in. Another one, could you do boosting of myeloid and NK cells at the same time?
Yeah, sure. That's something that we have optimized, is the ability to have more of everything into those boosted animals, especially important for ADCC related activities, where we know that macrophages and NK cells can play a role. So yes, we can combine the IL-15 boost with the GM-CSF, IL-3, IL-4, FLT3 ligand, all in the same animals, without losing any capabilities, any boost on the specific cells population. So yes, we get the best of the two boosts into the same animals regularly. Yes.
Great, thanks for that. Looks like we have just a couple more questions. After the tumor dissociation, were you able to effectively analyze all your key cell surface epitopes, or have you noticed any disruption due to the mechanical enzymatic digestion?
Yeah, that's a fair question. That's something that we have extensively checked when we set up those procedures that we have developed, as I say in the presentation, for the tumor, but also for many tissues into those humanized mice. It's quite rare. I would say that 95% of the time we do not have any issue with epitope. From time to time, we know that some epitope may be affected by the enzymatic digestion, so we can switch to just a basic mechanic digestion without the enzymatic step. So that's also a way when we know that we are working with very sensitive targets to mitigate that possibility.
Perfect. Thank you. We're going to wrap it up here. Thank you so much, Sébastien. Do you have any final comments for our audience?
No, just want to thank all the assembly for attending this seminar. It was a great pleasure to virtually be present with you today and present this quite interesting topic. If your question has not been answered, feel free to contact us at TransCure bioServices directly. You can do so by clicking on our website at transcurebioservices.com. You will find all the info details and many more information about the platforms that we have developed.
Perfect. Thank you again, Sébastien, for your time today and your important research. We'd also like to thank LabRoots and our sponsor, Miltenyi Biotech, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Like Sébastien mentioned, questions we did not have time for today and those submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. And we encourage you to share that email with your colleagues and anyone who may have missed today's live event. Thanks so much. Until next time, goodbye.